My name is Sidhanee. I'm a children's physiotherapist. I'm currently based at the Cromwell Hospital in London. I'm also a part-time physiotherapy lecturer at London South Bank University. I'm the co-lead of the PSYOP Rehabilitation and Physical Medicine Special Interest Group, and also the lead of World Physiotherapy's Childhood Cancer Special Interest Group. And I just put this photo up because you can see me, but I just put this photo up because it's actually where I met Judy. So I just want to say thank you to Judy for inviting me to give this talk. This was at the Barcelona Congress, the PSYOP Congress, at the end of last year, and this is me in front of one of our posters, which I will be talking about a little later in the presentation. So thank you again to Judy.
I don't see your slides moving. Is it just me or?
No, start the first slide.
Oh dear.
Sorry for interrupting you, but
that's okay. No, thank you for letting me know. So it should be a photo of me. That's not there.
No.
First slide.
Let me stop sharing and let me try again. Let's just.
That's right. Okay, now we can see your photo.
Okay, and I'm hoping you can see a full screen.
Yes.
Wonderful. So I'm moving from my photo just to say I have no conflict of interest. That you should see that slide.
So your slide is not moving on the.
Abu, can you hear me?
Yes, I can, yeah.
Yeah, so you're sharing PowerPoint and not sharing the presentation on Zoom. When you put share screen, just select like the whole presentation and not PowerPoint.
Let me see. So let me stop sharing and let me try that again. So did you say to share the whole screen?
You can either share the whole screen or just put the presentation up on PowerPoint and then share that one.
Yeah, that's what I think I'm doing. Let me just try.
No, you're sharing. Try to move again.
Okay, so it should say I have no conflict of interest.
Yeah.
Yes.
That's what we see. Yes.
And now.
Yes, now it's moving.
Yeah.
Okay, I'm just going to leave it on this. I think when I put it on a full screen, it doesn't seem to work. So my apologies. I'm going to leave it like this, and I'll just talk through the slides. So if you notice they're not moving, just say. Okay, so yes, what I was saying is thank you very much to Judy. Thank you to the networks for having me present today. I'm going to cover an overview of physiotherapy, prehabilitation and rehabilitation, a case study to highlight. I'm going to talk about global perspectives, the challenges and opportunities that we have, and then a little bit about the PSYOP Rehabilitation and Physical Medicine Special Interest Group. So moving my slide now. So I'm going to talk about physiotherapy, prehabilitation and rehabilitation, but I'm not going to do it in that order. I'm going to go backwards. So to start off with rehabilitation. Rehabilitation is a set of interventions designed to optimize function and reduce disability in individuals with health conditions in interaction with their environment. So it's key to look at this definition. It's not just about reducing problems or optimizing function. It's about the interaction with the environment. That's the key point here. And there's lots of definitions. This is a WHO definition. And you can see there are 4 domains, but you could argue there are more domains. But to keep it simple, these are emotional, physical, social, and cognitive. So rehabilitation requires a systems approach. There's emotional, cognitive, social, as I mentioned. But when I'm talking about rehabilitation today, I'm talking about it in a physical context, and that's around reducing pain, fatigue, improving function, strength, fitness, flexibility, balance, coordination, and control. So many domains that you may have come across in terms of physical rehabilitation. So that was a definition, as I've said, and there are many definitions out there, but it's key to think about what does that mean in our context for children and adolescents with cancer. And it means many things. So that may mean getting them back walking again, or them regaining their independence with tasks such as holding a pencil and being able to write. So why is rehabilitation required in childhood cancer? What we know is that 90% of children will present with symptoms such as pain, neuropathy, and fatigue while on treatment. And we know that 80% of survivors have at least one type of late effect that is related to their cancer treatment. So that means that almost 100% of children with cancer will need rehabilitation of some kind. And then also it's important to flag up the evidence. The evidence shows that physical activity and exercise have beneficial effects in cancer, and that includes childhood cancer as well. So I'll talk about this a little bit later, but there's a growing body of evidence that supports this. So now I move on to prehabilitation, also known as prehab or pre-rehabilitation in different parts of the globe. So prehabilitation means getting ready for cancer treatment in whatever time is available before it starts. So being more active and exercising, for example, is one part of prehabilitation. Nutrition, for example, is another part of prehabilitation. But it's important to recognize that in some circumstances, there is no opportunity to deliver prehabilitation. So where we can, we deliver, but in some circumstances, it's not possible. So the things that we might work on are strength, flexibility, balance, cardiovascular fitness, function and mobility, improving these where we can before cancer treatment starts. So what are the benefits of prehabilitation? Well, anecdotally, we know that we can get better surgical outcomes, we can have quicker rehabilitation, we can have improved physical and psychological outcomes, and we can have a faster return to social role. So that the evidence also shows that we have a reduced inpatient hospital stay, that patients cope better with side effects of cancer treatment, and that they experience fewer side effects. So I'm a physiotherapist, so I'm going to just quickly tell you about physiotherapy, but I'm not going to spend a lot of time talking about this because we are one professional group that deal with rehabilitation and physical rehabilitation. Physiotherapists provide services that develop, maintain, and restore people's movement and functional ability. They can help people at any stage of life when movement and function are compromised by processes such as aging or injury, diseases, conditions, or environmental factors. We have different titles in different countries. So here in the UK, I'm referred to as a physiotherapist. In some settings, such as the USA, they're referred to as physical therapists, or in some settings in South America, for example, they can be referred to as physiotherapists or kinesiologists. But essentially, we share the same professional background. As mentioned, I want to talk very quickly about physical activity and exercise. This is a topic within itself. So this is a rapidly growing evidence base. About 10 years ago, there was evidence that started to emerge in adult cancer, and that evidence has become very strong. But now in the last few years, we've seen a real evolution in the paediatric cancer evidence base. And that demonstrates that delivering physical activity and exercise to children during cancer treatment and after cancer treatment is both safe and feasible. And we have seen that it can have positive effects on both physical and psychological outcomes. So for example, on bone density, on body mass, on strength, you can have improvements, but also psychologically in terms of well-being and psychosocial outcomes, it can have positive effects. And we're also seeing incredibly protective properties. So there are studies out there that show, I'm sure you're aware that certain chemotherapies, for example, have negative effects on cardiac muscle and cardiac function. There are studies out there that show that people who are physically active, that can have a diminished response. So exercise can have a protective effect on that. And also in some adult studies, for example, colorectal cancer, studies show that in certain groups, you can get reduced mortality with people who keep physically active and have regular exercise during treatment. So really, it's a wonder why physical activity and exercise isn't considered standard care, and hopefully we will see in future, because of the evidence base, that it should be an adjunct to cancer treatment. So I'm going to have to go through a very brief case study just to put together some of these concepts of rehabilitation and prehabilitation. And I've just chosen bone tumors, but you could apply the concepts here to any pediatric cancer tumor group or pathway. The common challenges that we might see are pain, swelling, weakness, stiffness, restrictions, scar complications, for example. And the common aims for rehabilitation physiotherapy would be to improve strength, flexibility, balance, fitness, function, and mobility. So why would we, or why do we require rehabilitation? So blood vessels, muscles, parts of the bones can be removed along with the tumor, and there can be damage to nerves. Surgery can be very functionally limiting, resulting in restricted or altered range of movement. And walking aids or adaptive footwear may need to be considered. And patients sometimes require complex reconstructions or amputations. So meet Anya. Anya is 11 years old. She's got an aggressive distal femur osteosarcoma, a type of bone tumor. And she was diagnosed after a 3-month history of knee swelling. Otherwise, she's very well and is relatively asymptomatic. Anya, unfortunately, is at risk of fracture through the tumor site, so she has to be non-weight bearing. She has to use crutches, and that's for the duration of her 2 cycles of chemotherapy, which occur before her surgery. Anya is planned to have an amputation because she's got an aggressive tumor. Now, in some settings, resource dependent, Anya may be eligible to have a prosthesis, but in certain settings, if the availability of prosthetic replacement is not available, then an amputation may be the only option for Anya. So prehabilitation. The aims will be to maintain Anya's physical skills and abilities and improve those where possible. She's non-weight bearing, so we'll have to do the exercises in non-weight bearing to maintain the strength in her symptomatic leg. But on her other leg, she can work on balance and stability because she's going to need those skills after her surgery. Functional skills, for example, getting up and down steps or stairs and being able to get on and off the floor, we can teach those now, so Anya is ready for her surgery. And cardiovascular fitness, we know that she'll have improved surgical outcomes, so we can get her as fit as possible prior to surgery. And all of this helps with her psychological preparation, getting her ready for the surgery. So as mentioned earlier, it's getting her ready. Hopefully we'll have improved surgical outcomes and we'll have quicker rehabilitation. So the acute rehabilitation, so straight after Anya's surgery, our aims are to improve her physical skills and manage the symptoms that she has. So we've got to set aims and goals. Anya needs to get up and moving so she can get out of the hospital and go home. We've got to manage the pain, the swelling, get her stronger and get her leg moving on that operated side. And we've got to maintain those skills I talked about. So make sure that she can transfer out of bed, get up into standing and walk. And we've got to adapt now. So she hasn't got that leg, so we've got to use crutches, wheelchairs to get around. But we're restricted by guidelines. The surgeons will set guidelines and we're restricted by those guidelines at this stage. So many weeks to months afterwards, we move on to the medium to long-term rehabilitation. And the aims are to optimize Anya's physical ability and to return her to activity and her social role. So strength, power, balance, stability, coordination, high-level skills. We want her to be walking, but we want her to be doing other things as well. We want to optimize her gait pattern, so her walking pattern, and try to make it as efficient as possible. Again, build on that fitness. So it's later down the line, we can try to get her as fit as possible. Anya was fit and well prior to her surgery, and we need to get her back up to those levels of fitness now. We need to reduce the reliance now on things like the wheelchair and try to get her as independent as possible. And focus now on appropriate physical activity and sport. Anya might not be able to do everything she could do before, but there are things that she could do. And in terms of thinking about getting her back to her social role, it's important that we get her back to something appropriate. So before we were restricted by surgical guidelines, but now this is about an individual and personalized approach. Every child is different. They might have the same tumor or the same surgery, but they're all different. So we have a very individualized, personalized approach to what they like, what their aims are, and what they want to be doing. I move on now to talk about global perspectives. So we'll start with rehabilitation. So globally, 1 in 3 people live with a health condition that benefits from rehabilitation. And we know that this rehabilitation need worldwide is predicted to increase. So as globally people are living longer, as we have better health provision, as we have more cures for diseases, the need for rehabilitation is predicted to increase. But unfortunately, rehabilitation is often not prioritized, and it continues to be under-resourced globally. We know even at present that numerous countries are not currently equipped to respond to the existing rehabilitation needs, let alone the increase predicted. And in some lower middle income countries, over 50% of people don't receive rehabilitation services that they require. A little while ago, the WHO launched Rehabilitation 2030 initiative, and that aims to improve the awareness of and provision of rehabilitation and make it part of a standard part of care. And that will go some way to helping change these challenges of rehabilitation globally. So the benefits, we've got to think about the benefits as being individual and family, but also societal benefits. So we know with children with cancer that rehabilitation can optimize their function, their quality of life, their physical and psychosocial outcomes, and it can reduce their disability as well. And that is important to them. It's important to their family, their friends, their community, their school colleagues. But also rehabilitation has the effect to potentially impact positively on the burden of health resources and socioeconomic productivity. If we can rehabilitate people, then their burden on health service is going to be less, and also they will become hopefully more productive. They will be able to get meaningful roles and occupation, and that will contribute to local and national socioeconomic productivity. So these little diagrams here, this just gives you a little perspective about the economics of cancer. And this is data from the World Health Organization about the global annual economic cost. So this is the yearly cost of cancer based on 2010 data. And this number is so big that I didn't even know what it was when I first looked at it. But this is actually $1.16 trillion. And that is the annual, so the yearly global cost of cancer. So it's a huge amount in terms of the burden and the cost. The diagram on the right-hand side here, it was published in an article in the Lancet Oncology Commission in 2020. And it's specific to sustainable care in childhood cancer. And what it demonstrates is the red is treatment costs. So what it tries to show is for a relatively small amount of treatment costs. So if you invest, if a nation or a region invests in treatment, you get back a relatively higher amount of productivity. So by investing in treatment, you get back socioeconomic and societal productivity. What I've added on here is a little arrow upwards, because what we haven't necessarily considered at this stage is what if we invested in rehabilitation. So this is treatment, and treatment we hope leads to better cure, but it doesn't necessarily take into account the rehabilitation that survivors require. So surely if we invested in rehabilitation, we could bring that productivity up, and we could mitigate some of the huge economic costs of cancer. So what do we know? So we know through the WHO's Global Initiative for Childhood Cancer, which I'm sure that you're all familiar with, that we should be seeing more high quality, and we already are seeing more high quality cancer programs globally. And the goal of that program is 60% survival by 2030, and that represents a doubling of the current or initial cure rate, and which saves an additional 1 million children's lives over the coming decade. So we know that global survival for children's cancer is improving. Additionally, epidemiological transition, which is where the transition from conditions such as malaria, for example, to other conditions such as cancer mean that the relative burden of childhood cancer will increase. So we know there will be more survivors of childhood cancer. In many settings, we have to accept there is very limited access to care, there's very limited access to treatment, and that is always going to be the priority. But through these programs, we know now that that is improving. So our focus moving forward is that that cure alone, while it is something that we desperately need, it's not good enough. We need to think more than that, that cure for those children is not good enough, and we need to cure them, but we also need to rehabilitate them for all the reasons that I've mentioned before. So rehabilitation will be key to optimizing the quality of life of those childhood survivors. And not only those, but we've got to remember that some of those childhood cancer survivors will become adults, and they will live with the effects potentially of their cancer and the treatment. So what are our challenges? Well, the first challenge I've noted here is that rehabilitation can remain underutilized in many settings, with some settings reporting referral rates as low as 2%. Now, incredibly, this study is a study from the US. So this is not a low income setting, this is a high income setting, and they reported rates as low as 2%. So for reasons such as a lack of understanding about the importance of rehabilitation in childhood cancer, referral rates can be relatively low. Another big challenge is that specialists are very uncommon. Now, this is especially so in low and middle income countries, and the WHO reports that there are fewer than 10 rehabilitation professionals for every million people in some settings. I don't have comparative data, but that's an incredibly low amount of rehabilitation professionals to be able to serve a population. Additionally, rehabilitation services were also amongst the services most severely interrupted by the COVID pandemic. And again, that's directly quoted from WHO information on rehabilitation. Now, I want to just highlight that we need to just have the context when we're talking about income and resource settings. The difference between high income and high resource and low income, low resource, there can be differences there. So we will make an assumption that in high income settings, you can have high resource, but that is not always the case. I see that my co-chair, Pia Delano, is on this call, and she would very much agree that Chile, as an example, is a high income setting, according to World Bank, but doesn't always have in its settings high resource. So it can be quite low resource in terms of rehabilitation infrastructure. Where I'm based in the United Kingdom, we have got services and we are a high income setting that are incredibly well resourced. They have very good infrastructure, very good rehabilitation staffing. And in other settings, that is not the case. So there's a huge variation in rehabilitation. We can take it for granted in most occasions that in low income settings, you are likely to have low resource of rehabilitations, because the data does show that in low income settings, there is low resource. And as I've mentioned, that there are low percentages, for example, of rehabilitation professionals. But again, you can have variations to that. You can, for example, have a national specialist centre in a low income setting that has a relatively good rehabilitation infrastructure, but other settings in the country may not have services or may not have any services at all. So there can be variations, and it's important for us to understand that it's not solely about income, but that is an important and a significant factor. So I just wanted to show you a couple of bits of work that teams that I'm involved with that highlight some of this. This is an ongoing piece of work that is looking at data that was sourced by the PSYOP Global Mapping Team. Their pilot site initially looked at Africa, and I'm part of a team of people who are looking at that data, and we hope to publish this later this year. But this was a poster with the initial findings. It was presented a couple of years ago at PSYOP conference, and what it shows is that in terms of income settings of countries in Africa, not every country, not every resource setting reported to having physiotherapy availability for children with cancer. So the positive thing was that regardless of income setting, every income setting did report some availability, but that varied from 67% of settings in low income and 85% in lower middle income reporting physiotherapy services. So some of those settings did not report physiotherapy availability for children with cancer. So that is a demonstration that unfortunately that some settings because of availability or resource don't have availability to important rehabilitation services. And this is another project, again, co-authored with Pia, my co-chair, and this is our study looking at physiotherapy and rehabilitation services for children and young people and what happened during the pandemic. We got a range of responses. It was 13% from low income, but we got middle income and high income resources. So mainly weighted to high income, but we tried to get as broad a perspective as we can. And for example, 83% reported that physical activity levels of children and young people with cancer were affected negatively during the pandemic because of things, for example, such as the restriction and lockdowns. And 91%, so, you know, almost everybody reported some or a major disruption to rehabilitation and physiotherapy services. Again, services were closed, staff were redeployed. So we saw a major disruption to rehabilitation services during the pandemic. So I'm going to just sum up here now what the significance is. So we know it's very clear that survival is improving, and we know that there's going to be more survivors of childhood cancer. So the need for rehabilitation will increase. I'm just going to talk very briefly about the SIOP Rehabilitation and Physical Medicine Special Interest Group. We set this up. It's an official part of SIOP, and that's only within the last few months that's been set up. For the last best part of 2 years, we've been operating under the terminology of a task force. So we have been involved in various projects, some of those that I've showed you, but we are now officially with the accepted SIOP terminology, a special interest group. Very quickly, just to talk about the vision, and that is for rehabilitation and physical medicine professionals from around the world. We want them to collaborate, share good practice, so together we can advance care for children and young people with cancer globally. So that's in all settings. And for those of you that are interested, again, some familiar networks and working groups to you because you're all part of the same, but within the structure of SIOP, we are ultimately part of the Global Health Network, and within that network is a supportive care working group, and we sit under that as the physical medicine and rehabilitation special interest group. So our official email is there. It's peds-cancer-rehab@outlook.com. If anybody wants to get in touch, please do. If anybody is interested in either just understanding more, or have you got any ideas, or there's anything that you'd like to do collaboratively, please get in touch. I've also put my details there, my email and my social media details, if anybody wants to get in touch with me. I'm going to move on now just to kind of talk about physical medicine, rehabilitation and nutrition. And I've put this, we are like two peas in a pod picture up on different presentations that I've done, but I would like to think to a certain extent we are very similar in what we do, though we're professionally distinct. The way that we work and what we try to achieve with children and young people with cancer, there are very, very many similarities. So I think in terms of rehab and physical medicine, I think professionals, we can be guilty sometimes of thinking of that in a box and just thinking about exercise, physical activity in a bit of isolation. And the reality is that I particularly know that nutrition is hugely important, that we need to consider the role that nutrition plays in rehabilitation, physical medicine, exercise and physical activity. If young people don't have adequate nutrition, or nutrition is a challenge, that is going to compromise what we can do in terms of rehabilitation, exercise and physical activity. So there's a big link. if we can improve nutrition, that is going to improve the extent to which we can deliver rehabilitation, that we can have longer term effects, that we can have carryover, that we can get long-term gains. But it's not just before, it's afterwards. If we want to continue to see children and young people gain strength and gain fitness and see muscle improvements, then ongoing nutrition is really important. And therefore there's a link afterwards. Well, it's like a cycle. It's not just one thing that happens in isolation. The nutrition has got to be important through the pathway for us to get optimal gains in rehabilitation, exercise and physical activity. So what I'd like to think of is that it's more like this, is there's actually links together. And what we know, for example, is that the people who keep active, physically active and exercise, that can help manage things like body fat and weight. So actually there's links between physical exercise and nutrition. And also that we know anecdotally that children and young people who are active, who maintain healthy lifestyles, that can improve things like their appetite and help with things like improving eating habits. So there are very strong links between nutrition and physical activity. But I say all this, and this is easy to say if I was thinking about, for example, a child maybe in a high income setting who's doing really well, who has adequate nutrition. What happens when we add something like malnutrition in? What happens when we've got a malnourished child? And now we've got to think about everything that I told you before about exercise and physical activity being safe. Well, actually, we've got to think very differently when you've got a child who's maybe malnourished and who's going through the effects of cancer treatment. We have to really re-explore what levels of physical activity or exercise are safe with that group of children. And in terms of rehabilitation, it's not that we wouldn't do it, but we've got to think very carefully how we do that in a safe way. So what I've put up here really is just to start a conversation, to think that, especially now that we have a special interest group, that I think there probably is a piece of work. When we give out advice, we use very, very straightforward, common sense, if you like, advice. We tell people to keep well hydrated when they're doing exercise, to drink plenty of water, and we say to have a snack before and afterwards. So it's very sort of general advice, but I think moving forward it would be great to have, or to put together something maybe a bit more collaborative, so we could think about nutritional advice that we could give for people who are undergoing rehabilitation and physical activity, but also to start focusing, as I mentioned, on those populations that are more challenging. For example, the malnourished populations, where we have to think very much more carefully about the effects and the potential consequences if we don't get that right. So again, I go back to sort of talking about you know, why we are TPs in a pod, because you know, we deal with all the aspects, the holistic parts of children and young people, and the cancer is just one part. So we will focus as rehabilitation experts on their rehabilitation and physical medicine areas, but obviously their nutrition, their eating, that's another part. So we look at all those together, and that is about concentrating on the bigger picture, or the holistic care of children. So I'm just going to pop this up again. So if I've inspired anybody to get in touch, or anybody's got any ideas about collaborating about that, or about anything else that you can think of moving forward, please do get in touch. These are the references from my presentation. And I'm going to finish there, so I'm going to end there. So I think we have plenty of time. So once again, I would just like to say thank you to Judy and team. Thank you to the Global Health Network and Nutrition Supportive Care Working Group. Thank you for inviting me today. I'm going to stop sharing, and if we have any comments, any questions, please go ahead. Thank you.
Thank you so much, Abu. Yeah, like you said, we met each other along the posters in Barcelona at SILE, and he spoke that it was just very interesting to me, and I just immediately said, like, I'm going to get in touch with you because I want you to come and tell us more about what you're doing. And I think this is such such an important part. I thought of two things. Usually those children coming from ICU, but was on a ventilator, septic, and come to your ward, and then when the child stand up next to the bed, there's like no muscles left. And I don't think our doctors especially usually keep thinking of the physio still needs to come. Yes, the lung problem is now halfway solved, but now the physio needs to focus on something else. So that's the one thing I thought about. And then Minke, you mentioned something important then with the malnutrition here at the end. And I think that's something that we can really have a talk about maybe some collaboration, doing something that will really be of great interest to me. Does anybody else?
I definitely have a question, but I just want to give the floor first to others who called in. But if they're not, then I'm just going to take the lead on my question, if that's okay.
Yeah.
So I think, Abu, very interesting talk. I'm the co-chair with Judy for the nutrition group, and have been working in Malawi and Tanzania and Kenya quite a lot. One of the things I'm struggling always with physical therapy is, and I think as a doctor, I'm quite a fan of physiotherapy, as my husband is one, so he always reminds me that physio and physical activity should be high on my priority list. But one of the things I've been struggling with a lot in Malawi is actually, I was working with Prince. I think you might know him from the network. And Prince and I have been struggling a lot on like what to do with these very malnourished kiddos who come in. And he was asking me, how safe it is it to get them out of bed? How safe is it to get them with activities? And I actually said, I don't know. Just take it very step by step and see. And he said, so what kind of like exercise, can I start up with them? And for me, this was one big question mark. Also, the kids are most of the time very sick. They have a lot of side effects from the chemotherapy, so that doesn't help. But for me, this is a very big point of interest, and I'm happy you pointed it out, but also curious on what you think, what should be the way forward? How should we gain information on this so that we could have like proper either supportive guidelines? And this with two reasons, because from a physician standpoint, I don't know if we know what's needed and how. And secondly, more practical is that I see a lot of young physiotherapists in countries like Malawi, for example. They're very energetic, but they're not always to the max educated. And for them, it's really important as well to guide them on what they need to do. So two questions.
Yeah, and they're incredible questions, and I'm really pleased that you brought them up, because they show that we're thinking, I think, along the same lines. So the short answer is I don't know. So I don't have an answer about what we should be doing, and that is based on I don't have the experience. I work in a high income setting, but I think the question nevertheless is hugely valid, and I think we have to understand that question is a starting point, and we need to answer that question, and I think we are the community that probably needs to do that. So a few things I think that I'll mention, and I can see that Pia is on the call. She's my co-chair, and if she can jump in, or she was on the call, but she can jump in as well then. But the exercise and physical activity guidance that I mentioned during the presentation, that is all high income studies. So what it does, it says that it's safe, but it's in the context of children who have optimal nutrition. So we have to be very cautious when saying it is safe for children with cancer, because it is, but in the context of optimal nutrition and other factors in high income settings that allow that to be safe. So one of the things that I'm trying to work on is working with these groups to say, look, we need to link that research in with clinicians in other settings to see how we can apply it to those settings. It's not good enough just to say, look, it's safe for all children, because all children globally are not the same. So that is, I think, that the first thing is trying to kind of make sure these recommendations, we can try and interpret them to different settings straight away. Now, how we do that, that's the challenging thing. I wonder whether initially it needs to be some sort of consensus. For example, the exercise guidelines, when they first came out, we had something called, you all come across it, it's like risk aversity. So initially people said, oh no, people with cancer, you can't do exercise with them because it's unsafe. And actually consensus needed to come out first of all to say, actually, if you are doing it with this, this and this, and you keep it in these parameters, it's okay. And then the research backed that up. So it was slowly by slowly, but I think it's important we use consensus to think about where where we can do that safely. But then it's important that we have the research to back that up, to demonstrate that there are no problems. And I think, for example, and that's where I don't use like the word common sense, but I have to use the word common sense, that if we're doing gentle exercises, we're not stressing joints by using heavy weights or doing very explosive exercises, which we can do gentle exercises, because we can, for example, we work with people with metastatic bone disease, we can still do exercise with them. You just need to tailor the exercise. It doesn't mean you don't do it, you just do it carefully. So I think probably I'm trying to make the answer short now, is just, I think we need to have a conversation. We need to take the conversation forward. We probably need to start getting different groups of people together. So Minka, absolutely, we need doctors involved, we need dietitians, nutrition expertise, we need physical medicine people to come together to say, look, these are the benefits, but we need to do it in a safe way. How will we start doing that? And then longer term, I think absolutely we do ultimately need research to prove that. But it's important that what we don't do, and this is where I'm really keen to get across, is the research says that it's important and beneficial, and what we can't do is be so risk averse that we say just because children are encountering problems, we don't do anything with them. We need to do something with them, but it's how we understand what that level of safeness is, because that's always going to be the most important thing. Sorry, long answer. I hope that went some ways to answering.
No, thank you very much. I think that really enhances the issue. And I think another issue combined with that, if you have to, like in a resource limiting setting, where you have to choose between maybe 2 extra nurses and a PT, this is actually really important data. Why is it needed, and especially in what kind of population, or what could be a step-up approach. So I think we should, outside of this meeting, definitely talk more as to working groups within SIOP, if we can come up with something, which could be a step-up approach for departments in low-mid-income countries, with some consensus on what's safe and what to do with groups, which maybe also could come up with, could give us a frame line of what kind of studies would be needed. So I think, also speaking on Judy's behalf, but I think we as a group are very happy to move that discussion forward.
Great. And it's an important point that you raise as well, that I think it's important, and we certainly acknowledge that as a special interest group. We can't be precious and say only physiotherapists can do that, because that's not the reality. That there is not, there doesn't exist the infrastructure. So physical activity and exercise, it should be everybody's responsibility. So there's no reason with the right guidance that a nurse or a doctor or anybody in the setting can't say, look, what we know is that you should be moving, you should be trying to get out of bed, and we recommend that you do that. Obviously, if you do have rehab professionals, it's wonderful, but where we don't globally, we need to empower anybody working with a child. And that that even can be the children themselves and the families, to encourage that healthy activity, that healthy lifestyle. So we're working on that.
Yeah. No, perfect. Yeah. So let's keep that conversation going. Yeah. Thanks.
Thanks so much. Anybody else have questions? I just want to come back to the you said that you can train anybody, basically, if needed, to be part of the team. And I think, I don't know, probably the Kids Kicking Cancer organization, by huge in the US. So they come to us once a week, and he will adapt whatever the children feel able to doing that day. And I think just that little bit of getting out of bed and doing some yes, stuff really makes a difference. So yeah, I think that's quite important that you said that we can work on something. So yeah, I'm happy to be part of the next conversations about this, that we can maybe start getting some guidelines out there. But yeah, I will thanks very much for this wonderful presentation. I don't know if there's anybody else that maybe logged in later that wants to ask him a question. We did do a recording of it, but will be on YouTube, on the SIOP YouTube channel. But if there's anybody that wants to ask questions, we still have a few minutes before we need to log off. Okay. It doesn't seem like it. I will thank you very much for your time, and rearrange the time between South Africa and London, what exactly is the right time to have this meeting. But thank you very much. I really
No, you're very welcome, and thank you again. It's been great to make links, and I look forward to continuing the conversation.
No, we all definitely will. Thanks for everyone who's joining. We really appreciate it. And yeah, our next meeting will be at the last Tuesday of May. So thank you very much. Okay, thank you everybody. Bye-bye.
Bye.
Bye.
Bye bye. Take care. Goodbye.